Welcome, everyone, to this explainer covering the clinical management of hypothyroidism. With literally millions of people affected by this condition worldwide, it is absolutely crucial that we master its management. Today, we're zeroing in on the core Red Whale guidelines. So whether you're deep into your AKT exam revision or you're just looking to sharpen your clinical reasoning so you can better explain symptoms and treatment steps to a newly diagnosed patient, you are in the exact right place. We're going to break down this pathway step by step. By the end, you'll know exactly what to do, what to prescribe, and importantly, what to completely avoid. Okay, let's dive right in by addressing the golden rule right out of the gate. Do not diagnose based on symptoms alone. Seriously, this is a massive exam trap and a very real-world pitfall. Symptoms like fatigue, weight gain, feeling cold, they're incredibly common and wildly nonspecific. When you're explaining this to a tired, frustrated patient sitting in your consultation room, it really helps to tell them that while their fatigue is very real, thyroid symptoms are great mimics. We absolutely need the blood test as our compass before we start handing out a diagnosis. So here's our roadmap for today. 1. Who gets tested? 2. Interpreting results. 3. Prescribing rules. 4. Monitoring progress. And 5. Troubleshooting. Let's start with Section 1, Who gets tested? There's actually quite a variety of clinical triggers to keep in mind here. Obviously, you test for the classic symptoms, but the crucial point is keeping your eyes peeled for secondary indicators. For example, new onset atrial fibrillation? That's a huge red flag that should automatically prompt a thyroid check. Plus, since the most common cause of hypothyroidism is autoimmune Hashimoto's thyroiditis, you need a really high index of suspicion for patients who already have type 1 diabetes or other autoimmune disorders. When you're explaining this to diabetic patients, make sure to clearly communicate why you're testing them. Just let them know that because they already have one autoimmune condition, their thyroid is naturally a bit more susceptible. Oh, and in children and young adults, abnormal growth or sudden unexplained changes in school performance, those are prime indications too. Now, there's a delicate nuance here regarding when to test versus when to pump the brakes. You should definitely consider testing in patients presenting with depression or unexplained anxiety. However, you should not offer testing solely because a patient has type 2 diabetes. And here is a massive rule to remember for your exams. Do not test thyroid function at the time of an acute illness. Acute illness can temporarily alter thyroid test results, leading to a confusing clinical picture and potential misdiagnoses. Moving right along to Section 2, Interpreting Results. So, NICE guidelines recommend checking TSH first. If the TSH is abnormal, you then check the free T4. Though honestly, most labs automatically reflex to this anyway. Crucially, routine free T3 testing is not recommended for diagnosing or monitoring hypothyroidism. Just don't do it. If symptoms worsen or new ones pop up, you can repeat the tests, but you have to wait 6 weeks from the initial test before repeating because those levels take time to shift. Let's distill the diagnostic criteria down into a super high-yield memory tool. If your patient's TSH is raised and their T4 is low, boom, that is confirmed hypothyroidism. But if the TSH is raised and the T4 is completely normal, you're looking at subclinical hypothyroidism. Keep this distinction crystal clear in your mind. And when you're speaking to patients, you can reassure them that subclinical just means their body is working a bit harder to keep their thyroid hormone normal, but they don't necessarily need medication right this second. All right, Section 3, Prescribing Rules. Now this right here is classic exam fodder. For your standard healthy adult, the estimated treatment dose is 1.6 micrograms per kilogram per day, and you just round that to the nearest 25 micrograms. But if your patient is over 65 years old, or if they have known cardiovascular disease, you must start low and go slow. Begin them on just 25 to 50 micrograms a day and gently titrate up as required. Hitting an older heart with a massive dose of levothyroxine can literally precipitate angina or arrhythmias, and nobody wants that. You'll also need to warn your newly diagnosed patient that levothyroxine is, well, notoriously fussy. Explain to them that it demands to be taken on an empty stomach at least 30 minutes before breakfast. Caffeine and other drugs absolutely must be avoided at the same time to ensure proper absorption. Furthermore, despite what patients might read on the internet, guidelines strictly state we do not offer natural thyroid extract or liothyronine, which is also known as T3. There simply isn't long-term safety data for T3, and the vast majority of patients achieve perfectly satisfactory control with standard levothyroxine alone. Section 4, Monitoring Progress. Once they're on meds, your primary goal is straightforward. Aim for a normal TSH. If the patient is still symptomatic, you can definitely adjust the dose to optimize those symptoms, targeting a TSH at the lower end of the normal range. But hear me on this. You must not suppress the TSH below normal limits. Overtreating to the point of a suppressed TSH significantly increases your patient's risk of developing osteoporosis and atrial fibrillation. When counseling the patient, I like to explain that pushing the dose too high acts like revving a car engine in neutral. It just wears out the battery, which is their heart, and the chassis, which are their bone. Let's look at the timeline. You initiate treatment on day 0. From there, consider checking the TSH every 3 months until they're stabilized, which means getting 2 similar measurements within the normal range, 3 months apart. Keep in mind, TSH can take up to 6 months to completely normalize if it was initially really high. Then, once the patient is stable on their treatment, you just check their TSH annually. Easy. Finally, we reach Section 5, Troubleshooting. Imagine this super common scenario. Your patient returns to the clinic, complaining that they are still just utterly exhausted. You check their bloods, and their TSH is absolutely perfect. So what do? Do you just increase the levothyroxine anyway? Absolutely not. When the TSH is normal but symptoms persist, you need to broaden your differential. Consider checking for other autoimmune conditions or nutritional deficiencies like B12, folate, and vitamin D. You also need to explore other causes of fatigue. Think about things like sleep apnea, the onset of menopause, lifestyle factors like stress and alcohol, or even the side effects of other medications they might be taking, like beta blockers, opioids, or corticosteroids. Remember, we have to treat the patient, not just the numbers. Okay, let's flip the script. What if you're prescribing a seemingly optimal or even a very high weight-based dose of levothyroxine, say up to 2 micrograms per kilogram, but their TSH remains stubbornly elevated? This is what we call treatment-refractory hypothyroidism. Before you escalate the dose further or send off a referral to endocrinology, you have to play detective with their daily routine. Gently ask them not just if they're taking their medication, but how they're taking it. Are they taking it with things that block absorption? Things like food, coffee, soya, and grapefruit juice are huge culprits. Multivitamins, particularly those with calcium and iron, will literally bind to the thyroxine in the gut. Even common prescriptions like proton pump inhibitors can drastically alter absorption. Advise them to take it on an empty stomach with water a full hour before breakfast or any other tablets. Now, if their compliance and timing are completely perfect, you must look for systemic reasons why the medication isn't working. Is there an increased need for thyroxine? This happens with significant weight gain during pregnancy, or if they've started cytochrome P450-inducing drugs like phenytoin. Alternatively, do they have an intestinal malabsorption issue? You might actually need to check bloods for celiac disease, investigate for inflammatory bowel disease, or even check for infections like Giardia or H. pylori. Let's shift gears slightly to drug interactions. 6. Why am I giving you this number? Because this striking number is the multiplier you need to remember for patients on lithium. Taking lithium increases a patient's risk of developing hypothyroidism by 6 times. Amiodarone is another classic drug that can cause it, so always review a patient's full medication list when their thyroid function starts acting up. And this works both ways. A hypothyroid state dynamically alters the clearance and safety of other common prescriptions too. For instance, if a patient is hypothyroid, using statins actually carries an increased risk of myopathy. Additionally, the clearance of drugs like propranolol, steroids, and digoxin is delayed in a hypothyroid state, which means standard doses could lead to unexpected toxicity. It's a two-way street. Let's end with a really provocative scenario drawn straight from a recent MHRA safety update. What if a previously perfectly stable patient suddenly reports symptoms of hypothyroidism immediately after the pharmacy changes their levothyroxine brand? Well, while levothyroxine is usually prescribed generically, a small number of patients do genuinely report symptoms upon brand switching. If this occurs, consider testing their thyroid function. If symptoms persist, whether the thyroid function is normal or abnormal, the guidance actually suggests consistently prescribing a tolerated brand. It really begs the question, in a world of strictly standardized generic medicines, how much of healing still relies on actively listening to the unique, individual experience of the patient sitting right in front of you? Something to think about. Thanks for joining me on this explainer, and good luck with your revision and clinical practice.